Well, howdy, YouTube family. It is Bolt CRNA coming to you again with another day's topic. I have today Tom Baribeault here with me. Hey, Tom, nice to see you.
Yeah, you as well.
Tom is actually the creator for the Society for Opioid Free Anesthesia, and he is a CRNA who is actually progressing the field forward in anesthesia and actually pushing for things that he believes in that I think is also really awesome. So today we're going to talk a little bit about his background, how he started the society, and where he's going forward with it. So let's get into it. So Tom, before we get started into the Society for Opioid Free Anesthesia and what you're doing now, I want to know more about where you came from, how you became a nurse, what led you into the healthcare field, and ultimately what led you to become a CRNA.
Oh gosh, that's a long story. Originally I was going to be a musician. I played guitar and bass, in Boston. What happened is when I was 21, I was diagnosed with Hodgkin's disease and went through chemo and radiation and all that. And the place where I was getting treatment for that, I was just so impressed with the nurses there and their compassion and the quality of their care that I decided I wanted to do that. And initially my thought was I was going to go into oncology and take care of cancer patients. I wanted to really kind of give back. But what happened is, I got a job at the Ohio State University Medical Center doing patient registration in the emergency room, and because they would pay for school, pay for me to go to nursing school. So I was doing that full time while I was going through nursing school. And at the time I got out, there wasn't any openings available in the cancer hospital. But since I'd been in the emergency room for 4 or 5 years and developed relationships with all the nurses there, I was able to get a job working in the emergency room and did that for several years and decided that I wanted to go back and get a master's degree in nursing. And at that point, so I was comparing CRNA versus nurse practitioners and went and shadowed a CRNA and thought, God, this is just the coolest job ever.
Yeah.
And so that's what made my mind up. And then obviously had to transfer to the ICU, do my time in the ICU. Absolutely hated it.
Oh, really?
It was terrible.
Yeah. I mean, it's rough work. What did you hate so much about it?
So it was medical pulmonary. So, we had like a 50% mortality rate. And especially at a big medical center like Ohio State, they took all the sickest of the sick patients that got transferred in from, all the outlying hospitals that they couldn't get off the ventilators and things of that nature. So the patients were there for a very long period of time and very few of them actually recovered. So it was very depressing. It took a toll on my mental health for sure.
It's true.
But I put my time in and started applying to anesthesia schools and got accepted at Case Western in Cleveland, moved up there and went through the anesthesia program there.
Nice. So at what point during this process did you start to feel like you were leaning towards opioid-free anesthesia, or did you know of this at all while you were in training, or was this after school that you discovered this?
No, it was never my intention. I had never heard of it in school or really afterwards as I got out and practiced. It just ended up being the natural evolution of my anesthetic style. When I was in school, one of the projects we had to do is give presentations to the anesthesia group at the clinical site I did. And so one of the big things there at the time was use of esmolol drips to reduce opioid use and postoperative pain. And they had gone a little bit overboard with it. Like they would still run it on like patients under spinal anesthesia. They would run a low dose esmolol drip, and I was kind of like, this is crazy. You know, this doesn't make any sort of sense.
Yeah.
And so I chose for my presentation, I was going to, you know, look at the actual literature associated with esmolol infusions as sort of a passive aggressive way to tell people that, you know, they're doing it wrong. You know, because as a student, you have to walk that line very carefully. You can't tell people what you actually think, or that, you know, this doesn't make sense. But you can present literature, you can present research. And I'm kind of a jerk like that anyway. So, but so that was my intention. What I ended up doing, I couldn't find enough research on just esmolol infusions.
Mm-hmm.
You know, I found maybe a dozen studies, and you can't really give an hour-long presentation just on that. So I expanded it just to be, you know, other opioid-sparing modalities. You know, ketamine, lidocaine infusions, magnesium, nitrous oxide. And also looking at what's the actual physiology and pathophysiology of surgical pain, and how are all these various medications influencing that. So I gave that presentation, and that was sort of the start of it for me. And so I had like all these drugs, all these dosages, all these mechanisms in my mind. And when I got out, I was in a fairly independent practice and had the ability to sort of start to incorporate these into my techniques. And so, you know, you start out, you learn to use ketamine, and then, you know, I started doing some lidocaine infusions on top of the ketamine. And every time I incorporated another medication into my anesthetic technique and started getting confident with it, you know, the amount of fentanyl I needed to use got less and less. And, you know, it got to the point where, you know, I was giving 50 mics of fentanyl on induction, and that was it. And you've just got to ask yourself, why am I still doing this? Is there any benefit to the patient? You know, it lasts 20 minutes. This is a 3-hour surgery. Is there a benefit? Why am I doing this? But on the other hand, I'd never given an anesthetic without it. You know, so it's kind of like it's burned into your brain. This is necessary. This is, you know, part of the anesthetic triad is fentanyl. But, you know, I guess I'm the type of person that if I can understand something intellectually, even if it's a little bit scary, you know, try it out. And so for a week, you know, I would still draw up the fentanyl and label it and set it on the table. And, you know, I was able to sort of think to myself, well, what's the worst that's going to happen? You know, they get a little tachycardic when I intubate them, and I reach over, grab the fentanyl, and give it at that point, right? You know, it's a pretty low risk thing. But it was at that point that something, you know, amazing started to happen. And the patients started to do better without the fentanyl. Then you've got to chase down the reason why, you know. So I'm taking an analgesic away from my anesthetic, but the patients have less pain afterwards. And the fact that they breathe better and they've got less nausea and vomiting and things of that nature as well. And it wasn't until that point that I discovered that other people had done research on opioid free anesthesia, and there was literature out there to kind of support the practice that I naturally fell into.
Yeah. I know when I started school in 2016, that was when I started CRNA school. When did you graduate from CRNA school?
Years, so 15, 16,
15? Okay.
right in that area.
So it seems like about the same time, I mean, when you started hearing more about this and started having this bigger push for opioid free anesthesia and more people were talking about it, it was about the time I heard about it when I got in school, and it was a new idea. The professors, who mostly were older, were saying like, hey, this is the kind of a concept that's out there. People are doing this. You know, this is not necessarily my method, but you should understand the different methods and stuff. And you should understand like the mechanisms of actions and the ways that you can do things. Because my professors are very independent type CRNAs as well. And they very much were like, you should understand all different types of methods and then pick the one that you think is the best for your patient. And so we learned a lot about Opioid Free Anesthesia. And I remember your name, even way back then, maybe 2016, 2017, was like coming up even then as being kind of the cheerleader for this method. And then I think around that time is when you created the Society for Opioid Free Anesthesia, because I remember seeing it in school. Is that correct?
Right, yeah. And kind of how that came about is, I had given this presentation on just sort of multimodal pain management to the anesthesia group, and they had talked about it with other people. And so, even right out of school, some people were asking me to go to like state association meetings and give that presentation again. And I'd become good friends with Jeff Moulter. While I was in school, we met. He had given a lecture on the business of anesthesia to our class, and then I was one of the people from our class who went to mid-year assembly, and he was one of the chaperones or whatever they call them. So we had developed a relationship, and he was just starting the whole block buddy thing and starting to do regional anesthesia education. And so he invited me to come to his conferences, do my lecture on multimodal management, and run one of the regional anesthesia scanning stations. And then the group that I joined out of school, they did a monthly educational topic. And so they invited me to give that lecture to their group and to develop like some kind of cheat sheets that you could laminate and put in all the operating rooms so people would have a ready, kind of dose reference and contraindications and things of that nature at their fingertips. So all that, kind of snowballed. And at the same time, it was the beginning of some of these big Facebook groups for CRNAs.
Right.
And so I was on there, and, I was never really like pushing it or intentionally pushing it. I was just on there talking about what I was doing and the results I was getting. And, back then, no one had ever heard of it. And it was even to the point that, like, a lot of people didn't believe it was possible. There was a lot of like, well, you're going to cause harm and things of that nature. But at the same time, we were at the sort of the beginning of the really bad parts of the opioid epidemic. And so there was also a need for it, because you had all these patients coming in with heroin addiction on medication-assisted therapy. And I'm sure you're familiar with the frustration of trying to manage their pain and their hemodynamics with fentanyl. Their receptors are already occupied and dysfunctional, they're hyperalgesic. It doesn't matter how much you give them, they're hypertensive, tachycardic, they're in, uncontrollable pain. And so there was a massive interest in this technique just based on that. And so it was kind of this confluence of random things coming together that, I was able to sort of unintentionally get the message out. There was a need for the information and the knowledge. And so it very quickly escalated beyond my ability to provide the information, to answer people's questions, to get speakers out to all the conferences that wanted someone to come and present on this. And that's why I founded the society, is to meet this demand that was out there.
And I like how you mentioned the opioid pandemic that we were having, or epidemic, where that was such a huge issue, and it still is. But there was a time where that was the number one topic when I would go to mid-year assembly, like you mentioned, the AANA's mid-year assembly, where you go to DC, you talk to senators and legislators, and you lobby essentially and make connections and relationships with legislators. And I have sat in senators' offices before and talked about the Society for Opioid Free Anesthesia and the fact that CRNAs are spearheading this kind of movement of reducing opioids or eliminating opioids out of our anesthetics, which, can potentially help with that kind of issue with the opioid epidemic, because You have patients who are recovering, like you said, they're on medication therapies and stuff. They're recovering from drug addictions and issues, and they don't want you to introduce fentanyl into their system, or they don't want to be, given post-op, Lortabs and things like that. They want you to provide a block or lidocaine infusions they would prefer, and they're going to do better. Like, and I'm sure you can go into the physiology of it a lot better than I can. But a lot of this is much better too, like for their personal, healing and pain management. It's just better control, I feel like. And so that is something that, just talking to people in legislation and people who, we want to have good relationships with, I think it's really impressive that you did that and you created something like that, because it looks really good for us, and it's also something good for our patients.
Yeah, and that's it's funny. On one side, that's a big criticism of opioid-free anesthesia by people who don't necessarily understand it. Who and think that the goal is just complete opioid uh, elimination at the expense of the patient experience, or and that's not it at all really. If you go back in the literature and look at the first reports on opioid free anesthesia, it was introduced because of bariatric surgery. You've got these patients who, and back then it's an open procedure, it's not even laparoscopic, so you've got a 5-hour intensely painful surgery on a morbidly obese person who doesn't breathe well, with a high rate of postoperative nausea, vomiting, and poor pain control. And they needed a better technique that could manage those three things. And that's where opioid-free anesthesia really came from. But certainly the opioid epidemic added another sort of patient population to that makes it almost necessary to know how to do. And there's really two ways that it benefits that. One, you have to turn off the supply of people becoming addicted to opioids. And we know that opioid naive people coming in for surgery is a huge source of that. The number of patients who are still taking opioids 6 months, a year later after their surgery, after everything's healed, is unacceptably high. Mm-hmm. And, that's primarily due to poor pain control, leading to chronic post-surgical pain and inappropriate use of opioids. And opioid-free anesthesia is one way that we can reduce post-operative pain, reduce post-operative opioid requirements, and reduce the total opioid exposure to the patient.
Yeah.
And the other thing is, now we've had all these people who have become addicted to opioids, and like you mentioned, are now coming in for surgery. And so on top of their normal fears and anxieties of the surgery going poorly, of dying, of anesthesia, they've got risk. They're worried about relapse on top of that. They've gone through the addiction, they've gotten their life back together, and they're afraid of losing all that again. And so being able to tell them, we can get you through the surgery, no problem. You don't have to be exposed to these, the drug of your addiction. And certainly there's more than one trigger to relapse. Pain can cause it, anxiety can cause it. There's all sorts of triggers to relapse. So saying that opioid-free anesthesia is going to prevent someone from relapsing is unrealistic, but we can absolutely say it's going to reduce the chance,
Yeah, we can say we're not introducing anything into your system, and we're doing everything we can do to help you, reach a goal that you're aiming for as a patient. I actually have a lot of surgeons in the last, year or so. I've had a lot of surgeons requesting things like opioid-free anesthesia or opioid-reduced anesthesia. And you have a lot of what's called ERAS protocols, enhanced recovery after surgery, for a lot of things that, introduce lidocaine infusions, ketamine usage, tap blocks and things like that. Anything that you can do that's going to reduce the amount of opioids kind of that they're going to have to manage afterwards, that hinder your goals for healing and for the patient recovering quickly. So it's funny how this is kind of played out to where even the surgeons, request that type of anesthesia if they can.
Yeah, no, absolutely. And, the past 5 years, like we mentioned, the amount of literature and research has just become exponential. And so it's just becoming more and more popular and more mainstream. And, one of the things that is really coming out of this is, not just the patient experience, we're reducing rates of postoperative pain, nausea, vomiting, all of that. But what the literature is starting to show now is patients get out of the hospital faster with fewer complications. And even things that you might see as like surgical complications, like the patient bleeding and having to go back to the operating room to have that fixed. Well, if the reason they were bleeding is because they were hypertensive because they were in so much uncontrolled pain, things like that, we can keep their vital signs under better control with less postoperative pain. Then there's fewer of those types of complications. But things like less postoperative nausea, vomiting, all of those things contribute to the patient healing faster, getting out of the hospital faster. So that's not only a gain for the patient, but that's a financial win as well for the institution.
All right, guys, I had to cut us off real quick there because this video is turning into a very long one, so I'm going to break it up into 2 parts. I wasn't anticipating doing that, or I would have done this more eloquently, but you guys can look forward to a video next week with Tom where we finish our discussion about Society for Opioid Free Anesthesia, opioid free techniques, and everything else awesome out there. See you next time.